The emergence of new intravitreal therapies for retinal disease, especially macular edema of all etiologies, and greatly wet age-related macular degeneration, has revolutionized the outcomes for these patients to such an extent that it can be said that they now have a passport to paradise compared to some years ago where treatment options were very limited, especially in the field of wet age-related macular degeneration. However, new treatments bring new complications and there can be trouble even in paradise. One of the potential problems of intravitreal injections is direct lens injury by the injecting needle to the posterior capsule. Here's a case who had Kenalog injection about few years ago, and a cataract was induced within days with Kenalog being seen plastered to the posterior capsule. The normal phacoemulsification was attempted, and although things proceeded smoothly, once the nucleus was divided and two of the quadrants removed, the second heminucleus was chopped, at which point the posterior capsule split open even wider than it was initially. Phacoemulsification is therefore stopped and viscoat injected behind the nuclear material to stabilize it and to stabilize the anterior chamber, averting the risk of nuclear displacement southwards. The irrigation is gently withdrawn, and bimanual anterior vitrectomy with a low cut rate of 300 is used to try and remove the nucleus, which is not successful. The incision is enlarged and a vect is used to remove nuclear material, followed by repeat anterior vitrectomy to remove remaining lens matter. A higher cut rate is then used to go behind the posterior capsule rent and remove vitreous. Irrigation aspiration can then proceed almost normally, and once this is completed, the posterior capsule is tidied up and a 3-piece intraocular lens implanted in the ciliary sulcus, taking care to keep the external haptic and dial it in to make sure that the lens is placed in the sulcus without the risk of IOL displacement into the vitreous. The optic is then tucked in behind the capsular rhexis, creating an optic capture situation and a very stable lens position, following which the wound is sutured. Here is another case. However, this one has had a previous vitrectomy and developed a flaky cataract within days of an intravitreal injection. Because there is no vitreous, phacoemulsification can be done in a relatively routine manner, although the posterior capsule is open. Once IA has been completed, dilute triamcinolone is injected to make sure that there are no vitreous strands in the AC, and an intraocular lens injected into the ciliary sulcus with dialing in of the posterior trailing haptic, and the optic is then tucked in behind the capsular rhexis, again ensuring an optic capture position which provides a very stable lens placement, and further injections can be administered if needed. The typical injury is a needle track in the posterior capsule, as shown here on a slit lamp video. A posterior subcapsular cataract develops quite quickly. Sometimes a complete white cataract will develop. This is the same eye as shown on the slit lamp video on the operating view. A better technique is to use bimanual microincision technique using hydrodelineation but no delamination. A low bottle height is used, and as much nuclear material as possible is removed from the initial phacoemulsification procedure, following which the nucleus is bisected. Once we have two halves of the nucleus, we can remove fragments using high vacuum only when there is complete occlusion to allow turbulence. The irrigation going in anteriorly holds things in place, and no vacuum is used when the irrigating chopper is behind the iris plane. Hands can be switched, and each incision, both being of the same size, can be used to allow access to different parts of the nucleus which would not have been possible with a coaxial approach using one incision. The process of AC stabilization with viscoat before irrigation is withdrawn is repeated many times, and once as much of the nucleus which is removable has been removed. The parts which are in the superior half of the eye are mobilized with viscodissection using viscoat both to tamponade vitreous and move lens matter down into the lower parts of the eye where they can be accessed easier. Again, vacuum is only used when we have full occlusion, allowing removal of all lens matter without any displacement of nucleus into the vitreous. Continuing with the low bottle height and bimanual approach, irrigation aspiration is done to remove epinuclear material, keeping a very close watch for any presenting vitreous. A large part of this can be completed, but as soon as a vitreous strand is seen, aspiration is stopped and viscoat re-injected to re-inflate the anterior chamber and tamponade vitreous. Areas which are clear of the area of presenting vitreous can then be used to remove further soft lens matter. However, as soon as vitreous presents again, aspiration is stopped and a dilute solution of triamcinolone injected, which can be seen going through the posterior capsular rent. Anterior vitrectomy using a high cut rate of 600 and a moderate vacuum is started. The vitrector goes through the posterior capsular tear, but with no attempt being made to chase nuclear fragments, but waiting there for any which will come. As this is only soft lens matter, if a little bit is left, it can be left in the posterior segment and will resolve. Once the anterior chamber is clear of vitreous, IA is completed and the ciliary sulcus opened with Helon. The wound is opened to 3 mm and a 3-piece intraocular lens injected into the ciliary sulcus, keeping the trailing haptic outside the eye to allow me to check position of the lens in the ciliary sulcus and then dial the trailing haptic into the ciliary sulcus. Once that is done, the optic can be popped through the capsular rhexis into an optic capture position, ensuring a very stable position. The lens is now sitting securely with the haptics in the sulcus and the optic in the bag, but as I remove the viscoelastic, I have a doubt that I might have some vitreous still remaining. The classic solution of myocol is used. However, the pupil is round, but on staining with triamcinolone, again some vitreous is again identified in the anterior segment, which is again removed by bimanual anterior vitrectomy. Once this has been done, I can go home confident that on the next day there will be no anterior vitreous strands extending to the wound. Life goes back to normal, the shots can continue, and paradise has been restored to what it should be. Thank you for your attention, and I hope this video was useful.